So the history of modern genetics is actually the history of Down syndrome. So pretty much from the time that things started off to be understood about the genetics of modern genetic disease, we have been following Down syndrome. So it's named after John Langdon Down, who was actually the superintendent of a mental asylum, the photograph of which is there right at the top. Vast building that was built by the Victorians. And he saw that many of his patients looked alike. He called them Mongolian, and his observations about their features were published in a very classic paper in 1866, and I put the reference below that, where he called them, that paper was titled Observation on an Ethnic Classification of Idiots. So in those days, idiots meant that the grading of intellectual disability was in the range, the most severe ends were imbeciles and idiots. It was not meant as an abuse. And that's what he wrote about. And for the longest of time, they were called Mongolian or Mongols because of the Oriental look to their eyes. So it took nearly 100 years more to find out that chromosome 21 had to be extra to cause this disease. And it was in 1958 that we found that. And WHO in 1965 labeled it as Down syndrome. So Dr. Kishan had asked me, is it Downs or Down? And for all practical purposes, it's DOWN, and that's it. In 2000, the sequence of that, because ultimately every chromosome is a string of DNA. On that, like beads, are the genes. And when they sequenced the entire length of chromosome 21, they found that there were approximately 225 genes. And these 225 genes, when they are overexpressed or additional, the whole phenotype of Down syndrome happens. So if you go to the next slide, please, So what has happened? What is the current status worldwide? 1 in 750 live births have Down syndrome. It's not particular to one country over the other. There are many tests that are available, and we'll be talking about that as we go along. There are some non-invasive tests that have come along, and a lot of pregnancies that are tested positive wherever it's done, especially in the West, 90% and over opt to stop the pregnancy. But when you look at parental beliefs, they seem to feel, and there are many modern publications, that if there was much more support in society, better education, better societal support, they would prefer to continue. And these are the conflicting things about how we deal with things. Can you go to the next one? So what have we been doing over the last about 16 or 17 years? We have seen over 30,000 families. We've got them all graded and all our documents are with us. At least 1,600 patients with Down syndrome have been diagnosed. We do the karyotype and FISH studies for the diagnosis in our own lab at Center for Human Genetics. There are many cheap probes, less expensive ones that have been developed in our lab. We give genetic counseling services for all patients wherever, with or without cost. And of course, we coordinate prenatal diagnosis within the city itself and look for family screening where it's indicated, and that my colleagues will tell you where it's indicated. And with that, I will, if you just go to the last slide, this year's theme for, is that it? Okay, so this year's theme has been with us, not for us, for the Down syndrome. What it means is that walk with us, don't keep doing things for us. And it just reflects how much more independence and voice has come into this body. With that introduction, I would like to call my colleague, Dr. Vinu, who's consultant with me at Center for Human Genetics, to talk about the management of what do you do as a physician or a pediatrician when you see a child who has got Down syndrome.
Thank you so much, madam, for that introduction. So I'll be talking about diagnosis and management. And in a clinical setting, when we come across a 6-month-old child with features of flat facies, upslant of eyes, flat nasal bridge, protruding tongue, simian crease, clinodactyly, and hypotonia, and this is how the child looks like. then we all are very sure about that this is a Down syndrome diagnosis. However, even in a straightforward clinical diagnosis, it is very important to have a karyotype test. And to do a karyotype, all that we need is about 2 to 3 ml blood in heparin vial. And on an average, any lab takes around 10 to 14 days to provide a karyotype report maximum. And to have rapid results, one can order a FISH test, which is nothing but fluorescent in situ hybridization test, wherein the results can be made available within 48 to 72 hours. It is important to have a karyotype even in a FISH confirmed Down syndrome, because it is very important to know the type of Down syndrome, whether this is a free trisomy 21, wherein there is a extra chromosome number 21 sitting beside the 2 chromosome number 21, or whether this is a translocation Down syndrome, wherein the extra chromosome number 21 is attached to some other chromosome, or whether this is a mosaicism where there is admixture of cells with trisomy 21 and normal cells with normal number of chromosome, or whether this is Down syndrome like clinical picture, but the karyotype and FISH test could be negative, could be normal. So as I mentioned, about 100 cases of children undergo a karyotype. 96% of them may have trisomy 21 on their report. 3 to 4% of them could have Down syndrome due to a Robertsonian translocation. 1 to 2% of them have mosaicism, and less than 1% of individuals with Down syndrome are due to partial trisomy 21, wherein the critical region for chromosome number, critical region for Down syndrome is duplicated. And the Robertsonian translocation is, it occurs due to breakage of 2 acrocentric chromosomes. The acrocentric chromosomes are 13, 14, 15, 21, and 22. Once they undergo breakage at or close to their centromeres, if at all, if they with subsequent fusion of their long arms, it would result in a Robertsonian translocation, and this could be a balanced number or unbalanced number of chromosome. And the critical region is chromosome 21q22 for Downs-like phenotype. This is an example for Robertsonian Down syndrome, wherein the extra chromosome number 21 is attached onto the chromosome number 14, resulting in a 14-21 translocation Down syndrome. This is a 21-21 translocation Down syndrome. As you can notice, the third chromosome number 21 is attached to one of the chromosome number, chromosome 21, resulting in 3 chromosome number 21. And if at all, if a parent is a balanced translocation carrier involving the Robertsonian chromosome number 21 translocation, there is a 100% chance that each and every child born to such couple would have Down syndrome. And it is not uncommon to have a delayed diagnosis of Down syndrome, or Down syndrome being diagnosed in infants with hypothyroidism-like phenotype, as you can see in this newborn baby with coarse features, protruding tongue, small low-set ears. And this infant actually had congenital hypothyroidism, but was rather clinically diagnosed as Down syndrome in the newborn period. And it is also important to know the other differential diagnosis for Down syndrome with the appearance of similar facial phenotype. This could be seen in chromosomal disorders like Smith-Magenis syndrome, chromosome 9q34 microdeletion, and also in monogenic disorders like Zellweger spectrum, cerebrohepatorenal involvement. So having an established genetic diagnosis with laboratory tests is important to ascertain the risk of recurrence and to offer the right sort of prenatal diagnosis, which my colleague Dr. Surya would be elaborating on. And in addition to the facial phenotype, they may have cardiac birth defects like atrioventricular canal defects, ventricular septal defect, patent ductus arteriosus, tetralogy of Fallot, limb appearance like clinodactyly. There could be a wide gap between the first and second toe, single palmar crease, and a wide array of dermatoglyphic appearance, which is usually not performed these days. And in the newborn period, they do present with hypotonia and facial gestalt and sometimes excess nuchal skin. Many a times it is very challenging to ascertain Down syndrome diagnosis clinically in a newborn baby. And they grow on to have learning difficulties and with intellectual disability ranging from IQ of 25 to 75. Social skills are relatively well advanced and they are quite happy and affectionate children. On an average, the adult lifespan is about 50 to 60 years, and they have an IQ of about 40 to 45 and an average height of about 150 centimeters. Most of them in adulthood and later in life do develop Alzheimer's disease. And men with Down syndrome are usually infertile, whereas women with Down syndrome, 15 to 30% of them go on to have pregnancy. And there is a 50% chance of them having a child with Down syndrome in each and every pregnancy. So almost all 100% of individuals with Down syndrome have intellectual disability ranging from mild to moderate degree. Half of them have congenital heart defects, single palmar crease, hypothyroidism, and increased frequency of infection, and that could be due to immunodeficiency. Majority of them have a small ear length, and about 20 to 30% of them have risk of leukemia with transient abnormal myelopyosis. 3/4 of them have hearing difficulties, and that is mainly due to conductive hearing rather than sensory. And about half of them may have visual problems like cataracts, strabismus, and myopia. And of them develop dementia by the age of 65 years. In about 15% of children, autism spectrum phenotype is seen. 5 to 12% of them develop celiac disease in childhood. And 10% of neonates with Down syndrome have transient abnormal myelopyosis, if at all, if they have a mutation in the GATA1 gene. And this risk is maximum in the first 5 years of life. And about 6% of them may have GI anomalies like duodenal atresia and so on. And 2 to 3% of individuals with Down syndrome have risk of acute lymphocytic leukemia in their first 10 years of life. In the clinical evaluation of a newborn with suspected Down syndrome, of course, we need to do a karyotype. For rapid results, we may have a FISH test being done alongside and a complete blood count with differential count for surveillance for any transient myelopyosis, and thyroid function test to assess for any congenital hypothyroidism, echocardiography to rule out any congenital heart defects, ultrasound abdomen to evaluate for GI anomalies, and newborn hearing screen and follow up thereafter. In the surveillance, at every visit of the child, we need to check for the weight, height, and head circumference and plot it on a Down syndrome specific CDC growth chart. Check for the thyroid status with thyroid function test at newborn period, and then thereafter at 6 months, 12 months, and then once a year. Complete eye examination, complete blood count in the newborn period followed by once a year, and celiac screen starting from 1 year of age onwards once a year, and check for any symptoms related to sleep apnea in every clinical visit, and 4 years onwards monitoring for obstructive sleep apneas with polysomnography or pulse oximetry at sleep in appropriate clinical setting, and monitor for any mitral valve prolapse, aortic regurgitation with echo ECG in adolescence and adulthood in these individuals. And evaluation of the spine and spine care is a very important entity in the management of individuals with Down syndrome. Check for signs and symptoms in every clinical visit. And in suggestive cases, do a lateral cervical spine radiograph in the neutral position, order for an odontoid and AP view for assessing atlantoaxial instability or subluxation. If there are any positive signs, then MRI spine may be recommended. And in any individual with Down syndrome undergoing surgery or anesthesia wherein hyperextension of the head is involved, radiological screening for the atlantoaxial subluxation is very important prior to these procedures. Further on, we all know that pediatrician is the primary point of contact in most individuals with diagnosed with Down syndrome. Hence, it is very important to have a multidisciplinary team across involving a geneticist, developmental pediatrician, a team of therapists who can offer speech therapy, physiotherapy, occupational therapy, and surgeons, pediatric surgeons and cardiologists, if at all, if there are any anomalies to be operated for. And then, of course, we do have social workers and Down syndrome support groups helping out individuals and families diagnosed with Down syndrome. Early intervention and stimulation in infancy plays a very important role in managing these children, involving the physiotherapy, speech therapy, occupational therapy, and behavioral therapy, especially to get rid of undesired behavioral problems and to develop desired behavior in these individuals. And assisted devices like hearing aids in children with hearing problems, and incorporating newer learning techniques like touchscreen computers, computers with large keyboard, treatment of comorbidities like hypothyroidism, anemia, and celiac disease, avoiding obesity by ensuring a balanced diet, and surgical correction of the birth defects. Support groups that are dedicated for supporting families with Down syndrome, we do have in India, like the Down Syndrome Federation of India, Nai Disha, and then we have international groups like National Down Syndrome Society, which provide a wide array of information and holistic support to these families. So as Madam mentioned, this is the theme of this year for Down Syndrome Day, and with us, not for us. And this is a human right-based approach to disability, that is to have the right to be treated fairly and have the same sort of opportunities as everyone else, and working with others to improve their lives. Thank you. So my colleague will, Dr. Surya will take on to talk about prenatal diagnosis and newer research in Down syndrome.
Genetic counseling. It is a process. It is not a one-point thing. And it is a process of evaluating family history and medical records, making a clinical diagnosis, ordering appropriate genetic test, evaluating the results of the investigations, and ultimately helping the patients or parents understand the prognosis for the affected individual, inheritance pattern, and recurrence risk for the underlying genetic condition, and offering continued support. So for this session, let us take it in two scenarios. One is in a postnatal setting and the other one in a prenatal setting. So here we have a firstborn baby of a couple referred to our clinic with suspicion of Down syndrome. So here we have a simple pedigree where you can see that the couple is non-consanguineously married, and this is the first baby of them who is a male. And here on the left-hand side, you can see a clinical photograph, and from whatever description Dr. Vinu has given, the features are consistent with Down syndrome. So in the first session, when we are meeting the parents for the first time, we should spend time on getting a proper history and drawing a 3-generation or extended pedigree chart, complete examination of the baby, including anthropometry and documentation of all physical findings. And here we need to explain to them what is the underlying genetic condition. So here possibly Down syndrome, and why do we have to do the genetic testing, and what are we going to test for? So in this case, we have to do a chromosomal study. And what is the need for this confirmatory test? One is definitely to prove the diagnosis. Second is to calculate the recurrence risk. And also it is our duty to tell them what is the turnaround time for the test, meaning when do we get the report, and also the cost. And in the first visit, if there are any immediate medical issues, we should be addressing them. And also if the family wish to discuss anything else, that also should be addressed. So the primary goal in the first session will be to facilitate understanding and acceptance in the family members, and to explain the scientific cause behind this condition, and also to explore the personal beliefs of parents. So obviously parents will be in a different state of mind because they did not expect the diagnosis of Down syndrome in their baby. And also they must be sad about not having a baby as they expected. So when we go along the counseling, we have to uphold 3 principles, which are 3 N's. They are being neutral, 2, being non-judgmental, and 3, non-directive. Neutral is just being neutral, meaning not too excited, not very disappointed. No, you don't have to feel sorry or, oh, it's a bad news, nothing like that. Just be neutral in whatever you talk, so that the parents will have the freedom to think for themselves and take a decision. Second is non-judgmental, which is actually very difficult for all of us. But it is very important also. Just give due respect to the other fellow human being, and respect the life which he is going through, and just be non-judgmental. Third is about being non-directive. What do we mean by that? Here, it means that we don't have to be a traffic police in their lives and tell them to go this way or that way. Nothing. So our role is to give adequate information, up-to-date information, explain about the genetic condition and the anticipated outcome, and let the family take the decision on the basis of the shared knowledge. So now we have seen the family, we have given for the testing, and the first session is over. And when do we do the next session? The second session usually happens when the results are ready. So for karyotyping, we get the reports in around 3 to 4 weeks time. Fish can give the report even within 7 to 10 days. So here in the second setting, we are meeting the family with the results, and preferably both the parents offline. And here we have to explain the results along with the underlying cause, and try to explain all this in a simple way. Avoid medical jargons like meiotic, non-disjunction, translocation, and all those things. So here, usually when we give the report to the family, we sit with them and explain the karyotype report. So we tell them that we have got 22 pairs of chromosomes and 1 X chromosome and Y chromosome, which denote male sex or XX. And also that they are arranged in copies, 2 copies in the order of decreasing size. So as we take them along the chromosomes, they only can easily figure out that there is 1 extra chromosome. And that is the problem in their baby. So we have 1 extra chromosome, meaning 47, XY indicating that this is a male, and plus 21 to denote that there is 1 extra chromosome number 21. And now in this case, if we see, here again the same thing, from 1 to 22 we have to show them. But here what is happening? There are 221 chromosomes only, but the child is having features of Down syndrome. So where is the other one? So we have to again look through closely for any discrepancy in the size or shape of the chromosomes that we usually do when we report a karyogram report. And here, if you see, there is 1 extra piece over here. So here, if you see, there is no head, but on this chromosome, there is a head. I'm just using that word. It is to denote the short arm of the chromosome. So that is the problem in this one. And this is a translocation where the extra 21 chromosome has gone to chromosome number 14 and is sitting over there. So this is a fish report. Here again, if you see, there are 3, here we actually do the fluorescence. Dr. Vinu had explained, it's like bright spots. So with the particular probe for the chromosome number 21, when we highlight here, if you can see, all of them have got 3 signals, which means there are 3 chromosome number 21. So after explaining the reports, we have to arrange for parental testing, especially if we have a report of translocation. So one of the parents could be a carrier, and we have to do the parental testing. And also the next follow-up should be to discuss the results and recurrence risk of this. And this is a good opportunity to initiate discussion on their psychological and mental state, because during the first session, we had told them about the possibility. They must have read about it. They must have discussed with friends and even Google. And so we should know where do they stand. Also inquire about the family and personal support. And during this session, we should also encourage them to get enrolled with early stimulation therapy. Also talk about school support. Information should be given about where all the therapies can be accessed. But at the same time, make sure that we are not overloading them with information. It is absolutely okay if we have to take one more session to discuss all these things. And now when we get the report or when we have a clinical suspicion, there is always a question as to when to give the diagnosis. So it should be given as soon as possible, in person with both parents together, And it should be in their preferred language in a private setting, that is without any distractions like our mobile phones and other media. And it is our duty to give them accurate, up-to-date, and consistent information. And we should be sensitive, caring, confident, and talk in a straightforward manner. Always use a neutral language, I mentioned already. And be sensitive with the words you use. Avoid offensive terms like mental retardation. And as we go along, there could be pauses. It is okay. Allow time for silence. Let them take time to accept what they heard, validate their feelings. Also give information about the local and national support groups and share fact sheets or books. And this slide may look simple to you, but this is very important when we have any conversation involving a child with Down syndrome. So even during my MBBS days also, I'm sure I was excited and must have shown also, see, there's a Down child. I felt bad later on when I realized that we cannot say that. We should always say child with Down syndrome. Is it a disease? No, it is a condition or a syndrome. Suffer from. I suffer from fever. Do I suffer from Down syndrome? No, I have Down syndrome. Next is mental retardation. This is a very offensive term and we should not be using. We should always consciously use the term intellectual disability. And the other one, Madam had already mentioned, this is one of the very common mistakes everybody makes, with apostrophe S or without apostrophe, the Downs. It is just Down syndrome. And there have been studies conducted to find out about issues in counseling in our country. And these are some of the notable queries and beliefs. One is it a lethal condition? You all know that it is not. Whose fault it is, fathers or mothers? Down syndrome occurs due to improper antenatal care. Oh, I had eaten a pineapple, or something like I did not take iron and folic acid, and that is why I ended up with this. And will others recognize him as mentally retarded child by his look? This is again a major social stigma. Will he earn his livelihood? Will he ever be independent? All these are worries in parents' minds. And another common myth is heart defects need not be operated in children with Down syndrome. Do they have reduced life expectancy? We are told that he or she will not survive beyond 17 to 18 years. As of today, everybody knows that they grow well into 60s and even 70s. Will his or her children also have Down syndrome? This requires some evaluation. And the next is a counseling in a prenatal setting. So here, most of the times we get references after some ultrasound abnormality. And I'm sure Madam will be discussing this in detail. So here again, we have to do it in a stepwise approach. First is about revealing the probable diagnosis. Second is discussing with the family about the anticipated pregnancy outcome. Third is about decision on continuation of pregnancy, which is again, the family has to take a decision, and Down syndrome is definitely not a lethal condition or a fatal condition where they have to opt for termination. With proper counseling and guidance, most of the families nurture their child with Down syndrome. And also we have to discuss on the recurrence risk. So the discussion on recurrence risk completely depends on this basic classification of the cytogenetic abnormalities, where meiotic non-disjunction is the most common, 96%, and the recurrence risk for this is less than 1%. For translocation, the incidence is about 3 to 5%, and the recurrence risk varies depending on who is the carrier. Is it the mother or the father? Mosaicism, the incidence is about 1 to 2%, and the risk is less than 1%. For partial trisomy, with the occurrence itself being less than 1%, the recurrence risk is much, much lower. This is a busy slide, but I just want all of you to focus over here. So there are three main situations. One is pure trisomy, one is translocation, and one is mosaic trisomy. So just understand that in pure trisomy as well as mosaic trisomy, the recurrence risk is 1% or lesser above the baseline maternal age-related risk. When it comes to translocation, the middle part, it could be either translocation involving chromosome number 21 and a non-21 chromosome, or involving two 21 chromosomes. So whatever be it, we have to do the parental karyotype. and identify who is the carrier. So in 1421, for example, if mother is the carrier, recurrence risk is about 12%, whereas if father, this is about 3%. And if both parents are not carriers in any of the translocation, recurrence risk again remains the same. So if we find a child with translocation, the steps should be do parental karyotyping in the parents. And if any of the parent is a carrier, fetal karyotyping in the subsequent pregnancies is important. This table is available online, and whenever you come across a family, you can download this and go through this in detail. And one more point here, if the translocation is involving both chromosomes being 21, and either of the parent is a carrier, keep in mind that the recurrence risk in each pregnancy is 100%. So every time the mother becomes pregnant, there is a chance of the child having Down syndrome. So here comes the options for ovum or sperm donation. And now as they grow up, any child with Down syndrome is just like any other teenager. They also go through issues with self-esteem, self-care, pubertal issues, and sometimes bullying in school. They also are vulnerable. People exploit them, people abuse them, and they go through issues with pubertal changes and pregnancy. But over the years, the focus has shifted from health problems to social maturation and developing independence. And also transitional assessment is important. I'll tell you about this in a bit. So all the changes like emotional, behavioral, and physical changes which happen during puberty happen in a teenager with Down syndrome as well. So it is our duty to support positive behavior, helping them with understanding the pubertal changes about their bodies, boundaries, and sexuality. So we have got a number of literature to help us and the kids understand all these things better, just that they need proper guidance. So how can we help them? One is plan the transition, be it from school to higher education to employment or work activity, be it under the healthcare from a pediatrician to an adult physician. We need to understand the readiness of the child to be transferred. So that is called transition assessment. We should be encouraging them to be independent, make them a partner in day-to-day decisions rather than keeping them away saying that, no, you cannot give a decision. No, don't do that. Involve them in family decisions, involve them in activities in school and decision-making events, and support them throughout the different stages of puberty. And most importantly, now with everybody having access to internet and social media, educate them about staying safe online. Now coming to recent updates, ever since it was detected that the whole problem in Down syndrome is due to that one small extra chromosome 21, scientists have been trying to figure out if we can get that extra 21 removed, or can we keep it silent so that the other two work together to in a normal way. So there are a lot of articles available about translating the dosage compensation, about correcting the chromosomal trisomy, silencing the cyst gene. And the basic principle behind all this research is chromosome silencing, which we see normally in females, where one of the X chromosome is inactivated. So this is done by the cyst gene, which is the X inactivation gene. So once this gene is activated, it produces an mRNA, which actually coats the chromosome like a blanket so that none of the other genes are expressed. And ultimately, through a lot of heterochromatin modifications, this silenced chromosome is changed into a condensed bar body. So the research has been on to see if this can be used for autosomal silencing. So a sample was taken from a lot of children with Down syndrome. Fibroblast culture was done, inducible pluripotent cells were taken, and using the zinc finger motif, this gene was introduced into the one of the extra 21 chromosome. And they have seen in vitro culture that this extra chromosome where cyst gene was introduced got converted into chromosome 21 bar body. So there are a lot of studies happening. If you check clinicaltrials.gov, This is as of today. 307 studies are being conducted in Down syndrome, and the latest being the one which involves GM-CSF or sargramostin. This was actually studied in individuals with Alzheimer's disease to know if their memory can be improved. So the same drug is being studied in children with Down syndrome to see if their cognition and memory can be improved. So this is an area with a lot of activities happening. We are all hopeful that one day we get a good news to keep that the smallest chromosome number 21 in a silent way. So to summarize, this is the most common condition encountered in the genetics clinic, and the life expectancy and quality of life have significantly improved. And genetic counseling, the way we counsel, matters a lot. So we should focus on communicating the diagnosis to ensure that families receive up-to-date and balanced information delivered in a supportive and respectful manner. Continued and lifelong support with regular follow-up is a must, and we should definitely do that. So we all know that they are happy and trainable. They are more like other children than they are different, just that they need more time and commitment from our side. They can go to regular school or special school depending on their cognitive capacity. Participation in arts and sports is not a hurdle at all. They can get employed or start their own business, and we have a lot of examples around us. One is this girl, Aditi, who is in Navi Mumbai and is running her own business called Aditi's Corner. And the second one is Dinal Jain, who is a Special Olympics athlete in swimming, and she has won a lot of medals. So let me conclude my talk by quoting John Franklin Stephens from the USA, who is an advocate, especially for the people with disability, actor, Special Olympics athlete, who said, "I am a man with Down syndrome and my life is worth living." So we are beyond that era where people used to tell, okay, the child has some problem, terminate or abandon or neglect. No, we are in an era where these children are also not less than any normal individual, and they also have the right to live a successful life. So I am concluding here. I would like to thank Meenakshi ma'am and also the organizers and all of you who were listening to this. Thank you so much.
Thank you, Surya. I thought that was a brilliant talk. So, Dr. Vinu, if you put up my third the talk. So before I talk about prenatal, I think that what Dr. Surya highlighted was how we as medical people sort of assume that somehow people with syndromes have got less of an ability to be in society than the rest of us. So I was also like this. So early on in my genetics career, one day when I was practicing in Bangalore, I saw this adult with Down syndrome. He must have been about 24 or 25. And he had come with his father, who was a GP. And when I asked him, he said, "This is my only child. And when he was little, it was difficult to do a karyotype. So I've come along just to confirm. I do know he's got Down syndrome." So I asked, "Where is the mother?" And he said, "She's no more." So there was just father and son living together. And he was obviously trying his best to be of use at home. So I think in my, maybe in the way I spoke, maybe I said, "How do you manage? It must be really difficult." Then the father said to me, he said, "Madam, I'm luckier than others. People who have children who are doing well become software engineers and scientists and go away abroad and come once a year to meet their parents. My son lives with me and participates with everything that I do at home. We have to see who's the one who's having difficulty managing." So I think every time somebody speaks, and especially us, when Dr. Surya talked about being neutral and non-directive, I think this is what we mean, because our body language, besides our words, actually reach out to these families who are very sensitive. So coming back to my topic on prenatal diagnosis, As I said before, that much of our testing skills, which have been around since the late 90s, have been all directed towards early diagnosis in the hope that somehow you would be able to have early termination of an affected pregnancy. And sadly, this is true of many, many children. And maybe when all these new therapies come along, it might become so much easier for parents to actually opt to continue and then have treatments along. So when we talk about tests in pregnancy, there are two main types of tests. One category is called the screening tests, and the others are the definitive tests. So what is a screening test? A general screening test is a test that is applied to a large asymptomatic population, not a high-risk population, but just the population in large, in order to classify them with their likelihood of having a particular condition. So there are three main tests underneath this, which is the nuchal translucency scan, or the NT scan, which is done worldwide between the 11th and 13+6, that is just under 14 weeks of pregnancy. The second is serum screening. And whether you do it in the first trimester or the second trimester, you can do either a dual marker in the first trimester or a quadruple marker in the second trimester. And these two biochemical tests are done in a blood test from the mother, and they're combined with the nuchal translucency risks to see how we are progressing in assessing risk for that pregnancy. And the third, the latest child on the block, is the NIPT, which stands for non-invasive prenatal testing. You don't have to put a needle into the womb, and you can do other things about it. So definitive tests, of course, are the gold standard. It's either a chorion-villus sampling, or it is an amniocentesis, when you take fluid from around the baby and subject it to the definitive genetic tests. So if you go to the next slide, please. So talking about the screening tests, and can we go on a little bit more? I talked about the nuchal translucency. And if you actually look at the figure on the left side, sorry, Vinu, you're doing my job. So not that one, the one on the side. So there are two white spots there. So that is the back of the neck, and the slight dark line between those two white spots is the dependent edema of a fetus that's lying looking upwards. This is normally present, and the standard amount of thickness of that neck at different gestations is already mapped out. When you look at the right side, you really see that there are two blue arrows mark the boundaries of this sort of thing, and this is much wider. So measurements are available for this, but when you have this sort of measurement where there is a large dark shadow between the two white lines, the dark shadow indicates fluid. And this indicates that there is a lot of fluid that is accumulated at the back of the neck, or increased nuchal translucency. So increased nuchal translucency became the first antenatal marker for Down syndrome. Can we go to the next slide? So in addition to that, now there are about half a dozen to a dozen, depending on which center you go to. But this still remains the gold standard of how to measure and when to measure the thickness behind the neck of a fetus, and what position should the fetus be in when you're scanning or screening. And fetal medicine experts are very, very careful to see that it is done in the right time. So what did it show? What it showed was, in the early studies, that chromosomal abnormalities were far increased. Nearly a fourth of the children or the fetuses that had this sort of increased NT would have problems. Most of them would be Down syndrome, but it could be other chromosomal abnormalities. The thickness, the magnitude of the thickness also mattered. The thicker the back of the neck, the more likely it was to be associated with chromosomal abnormalities. And so there were several such studies, and of course with more markers coming in to assist this, like the nasal bone being present or absent, because these children have flat noses and delayed ossification of the nasal bone. There were other features that came along. But nuchal translucency is the gold standard for the first marker antenatally to be used. Next slide, please. So not only did we find that it was associated with Down syndrome, but there's a host of other conditions. And as you can see, there's a list of chromosomal disorders. But if you look at the last bit, you can either have isolated congenital heart disease and also sometimes skeletal disorders, lethal or non-lethal disorders, which may have elevated. So we just need to keep our minds open to see which of these would be associated with it. If you go to the next slide, please. So what do you do when you do a combined test? So when you do a dual marker test in association with the nuchal translucency findings, and you put it into a computer program that assesses dual risk, if you have the sensitivity factor measured, there's a 90% sensitivity to identify Down syndrome correctly with doing this. So what do you do in the dual marker test? You measure the two main hormones from the mother's circulation. One is HCG, and the other one is pregnancy-associated placental protein A, PAP-A. The placental growth factor is sometimes put in, but it usually is a marker for blood pressure being elevated or preeclampsia in the mother. So you add these findings together, put in the mother's age, and it will read off a risk factor. It will not tell you this is Down syndrome or not. It will tell you 1 in 250 or greater than 1 in 250 or less than 1 in 250, which is your cutoff mark. If you have, say, 1 in 100, that's a high risk. If you have less than 1, say 1 in 10,000, then that's a low risk. So bigger the figure, the lower the risk, because in every woman, there is some risk. There's no woman at any age that does not have a risk of having a baby with Down syndrome. And the age-related risk, for example, a 20-year-old may have a 1 in 1,000 risk, which is an age-related risk, whereas a 40-year-old may have 1 in 100, which is 10 times that much. But it still means 99 out of 100 women who are 40 will still not have a baby with Down syndrome. So backing on the age-related risk, you add in these two factors of an NT scan and the hormonal tests that are done in the first trimester. Can we go to the next one, please? But if you have missed that opportunity, and majority now centers do offer this, you can do the quadruple test, which is done anytime between 14 and 20 weeks. And the 4 hormones that are mentioned are out there. So the quadruple test uses maternal age, and then it doesn't use a scan, but it also uses beta HCG, unconjugated estriol, which is usually made by the baby's liver, starting with the placenta, of course, and then alpha-fetoprotein, which is on the baby's side contribution, and inhibin A, which is produced by the placenta. And you can see the arrows, which either being up or down, are indicators for different congenital abnormalities as well as trisomy 21. So here you use a greater than or less than 1 in 150 as being high or low, and it has gotten 80 to 85% accuracy as a good screening test. So there was a study that was carried out about 10 years ago to look at when you do prenatal diagnosis, what are the chances that you find different chromosomal abnormalities? The vast amount of the dark blue teal colored thing was, of course, trisomy 21. And then when you go up, you can see this little chunk in bright green, which is about 16%. And those are rare other chromosomal abnormalities. But if you look at the rest of it, nearly 84%, I think I'll call it, if my maths is right, it would fit into the things that can be covered by a single test, and this single test could be developed for the use of any X chromosome, 18, 13, 21, Y chromosome, and of course, these combined together became the basis of the next screening test. Can we go to the next one? And that was non-invasive prenatal testing. So non-invasive, as it mentions, is a non-invasive test. You don't put any needles into the mother's womb, but you're doing it for higher accuracy rates. When do you do it? In the West, it's mostly for advanced maternal age, beyond the age of 35, although you can keep guessing on what you would classify as increased maternal age. And abnormal ultrasound findings, something has been found on the ultrasound and you're not quite sure whether you want a real needle test to be done. Suspicious markers on the biochemical testing, personal history of any such past history. Somebody is really anxious that they've seen a neighbor, friend, or relative with trisomy 21, or a previous chromosomal condition that the family may have had. And of course, if there's been IVF treatment. So now the thing is, if you have IVF, lots of HCG is given, so you can't use HCG as a marker. So it will give you false high values. So you have to be careful about the type of screening that you require to be doing. And here NIPT is a better test. So can we go to the next slide? So what do you do as the principle of NIPT? Where is the fetal DNA coming into the mother's circulation from? The principle is all about measuring the tiny quantities of fetal DNA that is available circulating along with the mother's cells and mother's DNA in mother's circulation. So apoptosis of the trophoblastic cells that surround the baby are the ones that give rise to this free DNA. And it has got a major advantage. 48 hours after delivery, it all vanishes. So from a previous pregnancy, you won't have any residual DNA floating around. So in the mother's circulation is the vast amount of mother's DNA and a small quantity of fetal DNA. And in multiple pregnancy, it would be all the fetus's DNA floating around in the mother's circulation. From 10 weeks onwards, you can do this blood test in the mother, directly taking a sufficient quantity of blood. And within the next 7 to 10 days, you would get the result on this NIPT. So can we go to the next slide? So what do they do? The principle is simple. You take a blood sample from the mother. You have this mixture of green and blue, which indicates fetal and maternal DNA. There's a total amount. You're screening, you're doing next generation sequencing or massively parallel sequencing. And you're studying bits of DNA that indicate that there's chromosome 21. There's mother's 21 pair. And then you're looking at the babies, which you hopefully think is a pair, but there might be a third copy somewhere, whether it's translocated or whether it's a trisomy. So then you do a differential ratio. And this is what you're going to measure, the sensitivity of a differential ratio as compared to a normal value. And this is how you measure it. This can also be done in twin pregnancies to detect whether one or both twins have got trisomy 21. But for anything more than that, for multiple pregnancies, if there is triplets and above, it does not hold true, and we cannot get accurate results. In that case, you would want to do a direct testing. So this was revolutionary, and this was one of the quickest things that came from bench to bedside. Today, almost every lab offers it, and it is certainly something that can be done in early pregnancy. But if a woman is extremely fat or has come to you later in pregnancy, then you have to wonder about whether you want that as your first line, because it's a screening test. When the report comes, the report looks like this. And right at the top, at the right-hand corner, it's written fetal fraction 3-point-something%. So for the fetal fraction of DNA within the mother's DNA, you should at least have more than 4% or above for the gestation. So if you try this test very, very early, you may not get that desired fraction. Of course, laboratories will tell you that it's all right with 2.5%, we can still tell you, but you require a desired amount, and that's usually 4% for singletons and approximately 8% for twin pregnancies, whether you're looking at DCDA twins or monozygotic twins. And when you do measurement, can you see there's a whole list of things, trisomy 21, 13, 18, and then a few microdeletion syndromes, which can be, and as labs get more sophisticated, single gene disorders such as achondroplasia, sometimes now we're under experimentation to see whether hemophilia and thalassemia, which are more common disorders among the genetic disorders, can they also be identified. Beyond this, you need to know what is the sensitivity of this test. So for trisomy 21, it's greater than 99%. So 90% for the combined dual risk test and 99% for this test. So in some laboratories, especially I think in the UK, certain labs, they have actually moved this from a screening test into a diagnostic test for Tri21 or Down syndrome. But for others, there is a decreased level of sensitivity, and it should be used only as a screening test. If you get a high risk based on this, you need to go on and do a definitive test like an amniocentesis. So if you go on to the next slide, please. So there are other applications of NIPT. It identifies not just aneuploidy in twins. It can pick up small deletions, which are known as microdeletions, which cause specific syndromes. It can pick up monogenic disorders, as I spoke before. Autosomal recessive disorders is going to be the new next thing, including thalassemia. The Rh genotype, this becomes important because recently transplant medicine and the ethics bodies that rule it have said that you can have another baby if you're planning a Rh similar baby for a transplant, a bone marrow transplant or an organ transplant donor. And this can be looked for specifically. And of course, as life goes on, with about an 80 to 90% this thing, you can get whole genome sequencing of the fetus done, which will be revolutionary in the future, just from the mother's blood. Where we come to definitive testing, which is a yes-no answer, chorion-villus sampling is the earliest test. Chorion-villus is the developing placenta. It's the tissue in which the mother and the fetal tissue admixed together. It's done always transabdominally. In the past, it used to be done transvaginally also, but that caused a lot of infection. The earliest time that you can do it is beyond 11 weeks. Anything earlier causes complications. And when you have this admixture of fetal and maternal tissue, not only is it physically separated under the microscope, there are also additional tests done along with the DNA test that's done on this sample, and that is called exclusion of maternal cell contamination, which is a molecular test to remove any sort of micromixing. If you just go back one more, back to the previous slide, please. And of course, if you notice that the placenta is mostly always located on the anterior abdominal wall, along the anterior abdominal wall, but you have to be careful in case it's way low down where there might be some bleeding at the time of delivery, or posterior to the baby when it becomes more difficult to do. And in, of course, multiple pregnancies, you have to locate and fix the position of the placenta so that you don't mix up any sort of sampling. Go to the next one, please. Amniocentesis was the traditional and older test which is being performed since 1978. It means that you take a sample of the fluid in which the baby is being bathed, which contains cells that are shed off from the surface of the baby's body. The cells are fewer in number. You need at least 15 to 20 ml of the fluid. And then you can't do a direct test in majority of cases. You have to grow and multiply these cells. So you culture this. And all this adds to the time. Why do you do it 16 weeks and beyond? Because before that, there's less fluid around the baby. And if you take out 20 ml, it might cause anhydramnios or other complications for the baby. So you have to be careful how you do it. However, technically, it's much easier to do this test. So if you're doing a genetic test in this sample, you might get the answer at about 19 to 20 weeks, which makes it at the borderline of the PCPNDT Act, which says that medical termination of pregnancy, the limit is around 20 weeks, extendable now to 24 weeks. So we have to be careful that everything is done in time with the law. So next slide, please. So what do you do with that fluid? You grow the cells, you do the same thing. You can do a FISH for early results. There are other molecular, you can do an array CGH, you can do a traditional karyotype. And of course, the parents are anxious. So you're always waiting. And as Dr. Vinu said, even if you have a FISH test that is positive, you still need to wait for another secondary confirmation, which is either the full karyotype or an array CGH, which cross-verifies your result before you offer or suggest to the parents that medical termination is an option. Can you come to the next slide, please? So what are the complications of these invasive procedures if you stick a needle into a mother's womb? There is a miscarriage risk, which is approximately 1 in 100 to 1 in 300 chance, depending on the expertise of the person who's doing it and the sensitivity of the womb wall, because the muscle wall may go into contractions, which may bring on preterm labor. Amniotic fluid leakage can happen, and that may reduce the fluid content. It may also introduce infection into the amniotic sac. So those things, that's why they give a prophylactic antibiotic as a 1 dose prior to procedure. Bleeding into the amniotic sac if you hit the blood vessel through. Rh isoimmunization if the mother is Rh negative and the fetus is Rh positive. So we have to remember that they need to be given immunization for that. Early CVS, if you do below 10 weeks, it can cause limb defects because the blood supply to the peripheries may be cut off. And early amniocentesis can cause anhydramnios or a direct needle injury to the fetus. So these are some of the complications, more theoretical in trained hands than actually practical problems. So we have to remember that none of these tests, whether screening or otherwise, can ever be done if there is no pre-test or post-test counseling. And you have to be there before and after. It's not just the prerogative of the trained clinical geneticist, but usually we are the ones who do it. But anybody who has time and sensitivity should be able to do it. I'll leave you there, and we have left another 10-15 minutes for questions on any of the sessions. So please feel free to ask if you feel that there is something that's not clear. Thank you very much. Dr. Kishan, do you want to take over?
Thank you so much for a wonderful session. Excellent delivery of lectures. Meanwhile, we have some of the questions from our members. Mr. Sandeep Hegde is asking, ma'am, what's the reason for increased the translucency in chromosomal disorders?
I was rather hoping somebody will ask that. So, you know, if you are sitting for long in a flight or your leg has been in a cast, you'll find that there's distal swelling. So it is to some extent decreased movement and increased fluid in the dependent parts. So similarly, if a child has hypotonia or excess fluid caused by a congenital heart disease, for the fetus, the dependent part is really at the back of the neck because of the natural position. So it's naturally present to a certain extent, but it can become excessive if there is a condition which has a heart disease or hypotonia.
Understood. Next, Dr. Smita Sinchana is asking you, madam, please let us know the sensitivity of this NIPT test for twins.
You know, I was reading yesterday to see if there's any update. There are 10 mega studies recently, and they differ in the number of samples they have done and what they're looking at. In fact, NIPT has moved to another generation where not only are you, you can do it in PGD samples also, and that's another story. But I think the most important thing is that there is a variable amount of sensitivity with twins, whether monozygotic or dizygotic, which in trained hands and in large centers, which large studies are supposed to be the same for each type of aneuploidy as it is for singletons. It's always easier when there is a male fetus in there because you can cross-verify the Y content, Y chromosome content to check your answers. So almost similar to a singleton test.
Dr. Vinaya is asking how to diagnose Robertsonian translocation.
In what? Postnatal, prenatal?
Both, ma'am.
So if you're trying to look at postnatal, it's very easy. You take a blood sample, test it. You'll find it there. Well, it's called Robertsonian. It's a translocation, which means two things are stuck end on end. But Robertsonian, as I think Dr. Vinu had explained initially, the top end of the chromosomes are very short in 13, 14, 15, 21, and 22. And they're stuck end on end. So two Q arms of two different chromosomes stuck end on end is specifically called a Robertsonian translocation. Sometimes FISH can be used, but it only in expert hands. You can do array testing to find the extra full copy by doing an array testing, but you can also do just exactly our old traditional karyotype, which is the easiest way of picking it up, prenatally and postnatally.
Vinu, madam, whether you were telling about mother's age, what about father's age? Does the father age increases the risk of Down syndrome?
Generally, the advanced paternal age is seen in monogenic dominant disorders. It's unusual in chromosomal disorders. It's a phenomenon of non-disjunction and meiosis, either in the gonad, especially the ovum, or during the period of conception. So it's usually maternal advanced age that is known to cause chromosomal disorders rather than paternal advanced age.
I have to say the fathers are not spared. Older fathers are associated not only with single gene disorders, but there's a higher risk of autism or autism-related disorders, etc.
Dr. Mamata is a little worried. She's asking, Madam, nowadays we can see Down syndrome in younger mothers as well. Is it necessary to do Down screening in all mothers without any risk factors? She's asking you.
Me?
Yeah.
Yeah. So again, a common question that we have to see. So if we have to take 100% of people who are becoming mothers, women, the majority of them complete their family between 20 and 40. Therefore, the highest number of Down syndrome also happens in this bracket. It's not that the mothers have got younger. It's just that most people have their babies around that time. So that is what happens. And I had given you a relative this thing that if you are 40 years old, the chance is 1 in 100, which means that 99 out of 100, you won't have trisomy 21 as a result of age. But it's all relative to your age-related risk. So it's not that younger mothers are, there's no age where you're spared. Very young mothers and very old mothers have an increased risk of this non-disjunction.
And in fact, as per the newer guidelines, NIPT can be offered to any couple who are pregnant, and age is not a criteria anymore.
Okay. And our active member, Dr. Smita, is asking you, Dr. Surya, if you find ARSA on our nuclear translucency screening, is NIPT good enough for both Down and DiGeorge syndrome? Madam?
Yeah, can you repeat the question, please?
Yeah, if you find this ARSA is there on NT, nuclear translucency screening test, just NIPT is good enough for both distinguishing or identifying DiGeorge syndrome as well as Down syndrome, or do we need to separately go for some other tests?
Okay, so when it comes to NIPT, the sensitivity is supposed to be higher for the trisomies like Down syndrome and Edward and Petal. When it comes to DiGeorge syndrome, we have to, the most significant test is the FISH. So I don't think NIPT alone is enough to confirm the diagnosis of DiGeorge syndrome.
So the question I think they're asking is ARSA one of these things that, which is not an abnormality in itself, but if it is associated with other markers where you're worried that this could turn out to be a chromosomal condition, whether a microdeletion or a whole chromosome, when there's doubt, do an invasive.
Okay. Next question, unlike general population, in Downs, do we need to treat this subclinical hypothyroidism or not?
Not an easy question. So I think our endocrine colleagues wait for 6 months more beyond to do the next test and then see. I don't think there are many people that would jump in and test. On the other hand, I know that my senior colleague, Dr. Raghupati, used to always palpate the neck to see whether he could feel the thyroid gland. You know, that was something that was easy enough to do. So I don't think subclinical hypothyroidism, where it's still borderline, is something that people start treating immediately. Of course, different people feel differently, and I don't think there's any yes-no literature available.
We try and maintain the TSH values at least around the mean, so that, you know, from the recent studies, they've noted some psychomotor cognitive improvement with treatment of subclinical hypothyroidism. But again, we don't have enough evidence. There are varying practices in terms of closely monitoring subclinical hypothyroidism and treating them with very low doses of thyroxine.
So, you know, when Dr. Vinu was talking about management generally, she talked about screening for vision, screening for hearing, screening for hypothyroidism, and introducing early intervention. Just these 4 parameters and seeing that there are no surgical emergencies actually improve the cognition endpoints much more than, I don't know, people should not sit on young children diagnosed with Down syndrome. It makes a huge difference if we can optimize the basic senses that are being developed.